Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's December 2020 issue. There are 5 articles, 3 of which focus on COVID-19, that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is a special article that's entitled Best Practices in Managing Cardiac Arrest in the Emergency Department during the COVID-19 pandemic. It is authored by Dr. Heather Heaton and colleagues from Mayo Clinic in Rochester, Minnesota. The emergency department is faced with special challenges during the COVID-19 pandemic. As a major hub in the healthcare network, the emergency department ramifies widely through the network, and through its patients and personnel may spread the virus. The emergency department is a fast-paced environment that deals with life and death situations where the likelihood of droplet and airborne viral spread and viral spread by personal contact is relatively high. And the emergency department involves individuals with diverse expertise and disciplines, all coming together in a relatively contained space in the provision of patient care. Since the start of the COVID-19 pandemic, emergency departments have experienced an increase in the number of patients either experiencing a cardiac arrest or presenting in the early post-arrest phase after an out-of-hospital cardiac arrest. There are pathophysiologic reasons accounting for such increased occurrence of cardiac arrest during the pandemic. COVID-19 predisposes to cardiovascular diseases such as acute myocardial infarction, cardiac arrhythmias, myocarditis, and heart failure, and non-cardiac diseases such as acute respiratory failure, acute pulmonary emboli, and shock, all of which may culminate in a cardiac arrest. In the present issue of Mayo Clinic Proceedings, Heaton et al. Discuss management of cardiac arrest in the emergency department and provide guidelines for best practice. Their recommendations are founded on 4 central considerations, which are modified depending upon where the cardiac arrest occurred, namely in the emergency department or prior to admission to the emergency department, and whether cardiac arrest involved an adult or pediatric patient. The first principle seeks to minimize the risk to the healthcare team, as cardiorespiratory resuscitation and intubation are generally considered aerosol-generating procedures. Personal protective equipment, PPE, is essential, as is the entire exchange of the ambient air of the procedure room prior to the discontinuation of modified and airborne droplet PPE. The authors emphasize the use of a mechanical CPR device if the latter is available, not bringing the resuscitation cart into the patient's room, and the creation of a dedicated COVID-19 resuscitation medication kit. The second principle seeks to limit the number of aerosol-generating procedures. One way to achieve this is by attempting to reestablish an effective systemic circulation as expeditiously as possible. In this regard, shockable and thus potentially responsive arrhythmias should be targeted with a defibrillator attachment. Recommendations are provided regarding the transport of the patient from the emergency bay of emergency medical services if the arrest occurred outside the emergency department, and the transport of the resuscitated patient to the hospital. The authors discuss airway management, including endotracheal intubation, and when to exchange a supraglottic airway to endotracheal intubation. The third principle recommends limiting the number of personnel to those essential for the resuscitation team, and that ancillary responders should only enter the resuscitation room if specifically indicated by the team leader. Drawing upon the evidence that resuscitative efforts for cardiac arrest in patients with COVID-19 extending beyond 10 minutes are quite unlikely to achieve patient survival to discharge, as well as other considerations, the fourth principle reflects on the duration of the resuscitative efforts and when should such efforts be terminated. As concluded by Heaton et al., these 4 guiding principles inform a best practice model that guides the management of patients with cardiac arrests in the emergency department and is attentive to, among other issues, the safety of healthcare personnel, the prevention of viral spread, and relevant ethical issues. Our first highlight includes two articles. The first is a special article entitled Substance Use Disorders and Telehealth in the COVID-19 Pandemic Era, A New Outlook. It is authored by Dr. Tyler Osterly and colleagues from Mayo Clinic in Rochester, Minnesota. The second one is titled Non-Invasive Positive Pressure Ventilation in Patients with COVID-19. It is authored by Dr. Claudia Dobler from the Institute for Evidence-Based Healthcare, Bond University, Gold Coast, Queensland, Australia, and colleagues from Mayo Clinic in Rochester, Minnesota. Addressing and adapting to challenges such as the myriad ones posed by the COVID-19 pandemic commonly lead to new approaches and/or reappraisals of existing ones. Such therapy is curtailed by constraints imposed by the COVID-19 pandemic, thereby necessitating alternate approaches. Osterly et al. Review the role of telehealth in providing such therapeutic approaches and covers the spectrum of relevant modalities, including computerized assessments, telephone-based recovery support and therapy, video-based therapy, texting, smartphone apps, and virtual reality interventions. The authors provide specific recommendations regarding the best practices for telehealth visits as applied to both the provider and patient, the conduct of an addiction-focused telehealth visit, and the conduct of a telehealth medication-assisted treatment visit for opioid use disorders in general, and for buprenorphine home induction in particular. While telehealth is a relatively novel and burgeoning approach in medical practice, non-invasive positive pressure ventilation, comprising continuous positive airway pressure, CPAP, and bilevel positive airway pressure, BiPAP, is a well-established therapy in respiratory failure. However, as pointed out by Dobler et al., there is a spectrum of recommendations by various societies and organizations regarding the use of non-invasive positive pressure ventilation. Such use is either not even considered, supported in certain circumstances, or entirely opposed. Dobler et al. Begin their discussion by underscoring three salient considerations. First, concerns such as ventilator-induced lung injury surrounding invasive ventilation via either endotracheal tube or tracheostomy. Second, acute respiratory distress syndrome due to COVID-19 may differ from classic ARDS because ARDS and COVID-19 usually exhibits prominent ventilation-perfusion mismatch with preservation of lung compliance. And third, the relative roles of CPAP in alleviating hypoxia and that of BiPAP in mitigating hypercapnia. The authors review the available literature regarding the benefit and adverse consequences of non-invasive positive pressure ventilation as compared with early intubation in COVID-19. They also discuss the benefit and adverse consequences of non-invasive positive pressure ventilation as compared with oxygen administration and high-flow nasal cannula in patients with acute hypoxemic respiratory failure due to COVID-19. And finally, they discuss the risks of viral transmission to personnel with non-invasive positive pressure ventilation and high-flow nasal cannula. The authors conclude their discussion with a call for randomized clinical trials, and they speculate that until such evidence is available, a case may be made for the consideration of non-invasive positive pressure ventilation as an alternate strategy to early intubation in patients with COVID-19. As reflected by these two articles, novel modalities and/or reconsideration of established modalities both have a place in the current crisis. Our second highlight contains two original articles. The first one is entitled Temporal Trends in the Resource Utilization, Cost, and Outcomes of Transcatheter Aortic Valve Replacement in the United States. It is authored by Dr. Akram Kasawa from West Virginia University in Morgantown, West Virginia, and colleagues from Mayo Clinic School of Medicine, Rochester, Minnesota, and the University of Kentucky in Lexington, Kentucky. The second is entitled Transcatheter Aortic Valve Replacement versus Surgical Replacement in Patients with Pure Aortic Insufficiency, It is authored by Dr. Anas Alhabi from West Virginia University in Morgantown, West Virginia, and colleagues from West Virginia University Heart and Vascular Institute in Morgantown and the University of California, San Diego in La Jolla, California. Achieving the same clinical objective while minimizing risks and adverse outcomes is a general principle that both underpins medical practice and sustains a steady stream of biomedical innovation. In this regard, the introduction and the continued refinement of transcatheter aortic valve replacement, TAVR, represents a major advance in the management of patients with aortic valve stenosis. In patients with severe aortic stenosis in whom the surgical risks are prohibitive or high, TAVR affords the possibility of a new functional aortic valve placed at a vastly reduced risk that is otherwise imposed by surgical aortic valve replacement, SAVR. Introduced as a feasible therapeutic option less than 20 years ago, TAVR for severe aortic stenosis is now approved by the U.S. Food and Drug Administration for application in patients with lesser risk, including those with even lower risk. TAVR is thus a remarkable example of how targeted innovation can transform the practice of medicine, including in ways never anticipated when such innovation was initially introduced. In the present issue of Mayo Clinic Proceedings, these two articles provide important contributions to the TAVR literature. Recognizing the evolving nature of this field and the need for more recent information on outcomes and costs, Kasawa et al. Analyzed information in the National Readmission Database pertaining to patients who underwent TAVR between 2012 to 2017. In a population of more than 89,000 patients, analyses over this time frame demonstrated a decrease in the following outcomes: in-hospital mortality, length of stay, non-home discharges, and the cost of TAVR hospitalization. Rehospitalizations were all decreased over this time frame, as was the need for dialysis, mechanical ventilation, or blood transfusions, or the occurrence of vascular complications. However, the need for pacemaker implantation and the occurrence of strokes were unchanged. With an increasing number of patients receiving this procedure from 2012 to 2017, the in-hospital costs related to TAVR increased fivefold. The accompanying article by Al-Habi et al. Assess outcomes regarding the use of TAVR as an off-label procedure for patients with pure aortic insufficiency, who were at high risk for SAVR, the latter representing the preferred and standard treatment. Using the National Inpatient Sample Database, Al-Habi et al. Analyzed outcomes in more than 14,000 patients with pure aortic insufficiency who underwent valve replacement, 93.8% by SAVR and 6.2% by TAVR. While considerably older, the patients who underwent TAVR showed comparable in-hospital mortality as compared with those who underwent SAVR. After propensity score matching, patients who underwent TAVR exhibited less acute kidney injury, cardiogenic shock, and respiratory complications, a shorter hospital stay, and were more likely to be discharged home. They also exhibited a marginally diminished cost of hospitalization, but a greater need for permanent pacemaker. Based on these encouraging retrospective findings, the authors conclude by emphasizing the need for randomized clinical trials that evaluate TAVR and SAVR for pure aortic insufficiency. These two studies are timely, important, and complementary. The one by Kasawa et al. Documenting the steady improvement in outcomes and the reduction in costs. The other by Al-Habi et al. Raising the possibility of new avenues of approved use of TAVR. You can access these highlights and editor choice articles free of charge during the entire month of December. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you'll find links to our social media by clicking the buttons at the top of the homepage to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the homepage, as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.